Some of you may have attended the previous session that I did on consent, which was, I think, about 6 weeks ago now, and it seemed to be sort of reasonably helpful for people. And so this is kind of building, this session is building on that, because I'm going to talk about capacity. My history is that I am a full-time NHS consultant anaesthetist in London, but I have a dark history in that I was a barrister before I became a doctor. And since working for EveryDoctor, I've kind of resurrected my practicing certificate. So I do mostly actually sort of employment law type advisory stuff, a little bit of regulatory work, but basically advising members. And so that's kind of what I do with that bit of my life. But we thought it would be helpful to try to do some of these sessions because so many of these issues crop up all the time in our day-to-day practice. In fact, I've had 2 or 3 in relation to capacity in the last 2 weeks myself at work. And it's just something that's not very well taught for those of kind of my vintage. I'm sure you're all a much sort of younger vintage than me, but for those of my vintage, then it wasn't really taught at medical school at all or well. And I think it needs to be. I suspect things are changing a bit, but it's really, really important stuff. And we kind of end up having to just sort of feel our way and find our way through it. And that's not really good enough. It's not good enough for our patients, but it's not good enough for us as well. It's not fair on us. So hopefully these sessions will help to just sort of give you I can't dig into absolutely every single detail, but I hope that I can give you a really useful overview. You can see my email address is at the bottom there, my EveryDoctor email address. So if you've got any questions, either that I can't answer, because that's entirely possible tonight, I'm happy to go away, look it up and come back to you, or just things that crop up for you after the session that you'd like to, you sort of think suddenly, oh crikey, this happened with a patient 6 months ago. And if you have ongoing issues, if you've got a problem and you're not sure what to do about it, then do feel free to drop me an email, and if I can help, I will. So email address is at the bottom of the screen there. That's my Twitter handle as well. I don't tweet about a lot of legal stuff, but we'll probably start to tweet about a bit more, I think. But that's where you can get sort of information from me. And then obviously there's the EveryDoctor Twitter handle as well, and Julia's. So I'm going to just sort of get started slowly and gently and ease everyone into this. So I've talked about consent last time, and I'm going to talk about capacity, and those two things are really kind of intertwined. I mean, they're sort of almost two sides of the same coin. So I remember this from last time. I have to do it clicking the screen. So just a quick little sort of recap of these sort of pillars of consent. I'm loath to use the term pillars after pillars of testing from the pandemic. It sends shivers down my spine and gives me PTSD from all those dreadful press conferences that Boris Johnson and Hancock held. But anyway, the pillars of consent are, so first of all, capacity, a patient who has capacity to make a decision to give or withhold consent. Information, so that's what our last session sort of really focused on in terms of consent. What do we have to tell the patient? What is the information that we must give them in order that they can make this decision? So I'm not going to cover that in any detail. As I say, the video from that session is on our YouTube channel, and feel free to go and have a look at that. And again, I'm happy to answer any questions via email that might arise for you out of that session if you didn't see it at the time. And the last one is voluntariness. So we're going to assume that we're not strapping patients to chairs and doing bad things to them, that voluntariness is not really the kind of the issue for us. Sorry, I'm trying to admit people as well as speak. So let's just, we're gonna take these two out of the equation, and we're going to focus on capacity, but just to sort of put it in context and explain how these things are intertwined. Capacity is one of the kind of the key pillars of giving a valid consent or obtaining a valid consent. So first principles in relation to capacity. This is the main principle, which is I'm in charge of my life. I can do what I want. It's up to me. Any person who doesn't have a mental impairment absolutely has the right to control their own body, and no one can consent for another person. And this is something that I, as an anaesthetist, come across still so frequently. It drives me crazy with surgeons of varying grades and levels of experience and years in the job telling me that the patient hasn't consented, but the relatives consented for them. No one else can consent for another person. The Court of Protection can. We can act in the patient's best interests, but nobody else can say, yeah, it's fine to go ahead and do this for this person. So no one can consent for another person. So basically, yeah, I'm in charge of my life. I can decide what happens to me, except in a certain fairly limited number of circumstances. So sorry, that bing bong suggests there's someone else trying to get in as well. So bear with me if I'm doing that too. So those exceptions are unborn children, children under the age of 16, young people aged 16 to 17, so i.e. sort of 16 and under 18, are an interesting category. So they may have sort of Gillick competence and Gillick capacity. And I'm not going to go into that in detail today. I think probably what we'll do is do a separate session on pediatrics, sort of medico-legal issues in pediatrics, because there are myriad issues there. But essentially, young people aged 16 to 17 don't have capacity, and then adults who lack mental capacity. And for them, there are various jurisdictions that govern what can happen, what can and can't be done. This is very old-fashioned parens patriae jurisdiction of the courts, which is a sort of parental role that the courts historically could discharge, and in very rarefied circumstances they might sort of turn to it, but they don't really need to anymore, because we've got the common law. So case law gives us a lot of guidance. The Mental Health Act, which deals with clearly with mental health problems as opposed to capacity problems, although there can be some overlap. But someone who has a mental health problem does not necessarily lack capacity, and vice versa. Human Rights Act, so right to privacy, and pretty rarely used. But the main one, the key bit of legislation in relation to this particular area, is the Mental Capacity Act of 2005. So I'll kind of dim those other ones down. I'm going to focus on the Mental Capacity Act, because that's the nub of it, and that's probably what we're all dealing with day to day in our practice. So Mental Capacity Act 2005. There's also a pretty lengthy code of practice that goes with it that's not very widely advertised, but it's actually quite useful. It's a couple of hundred pages, and I would read a guide to it as opposed to the sort of the nitty-gritty of all of it. But it gives some really useful pointers and practical tips, and expands on some of the stuff that's in the Act itself, which in parts is a little bit kind of it's a bit concise, really, for such a complex area. So if we look at Section 3.1 of the Mental Capacity Act, it's obviously the natural place to start is Section 1, but we're going to go to 3 subsection 1, because that is where the sort of the definition of capacity and what constitutes capacity is set out. And that's basically that our patients have to be able to, in relation to information that we give them in order that they can consent to something or refuse consent or withhold consent, they need to be able to understand the information that we're giving them. They need to be able to retain it. They need to be able to weigh it in the balance. So to, sort of take it and look at it from all angles and weigh it up and decide, and then communicate the decision that they've come to. And we're going to just take a little sort of step back and examine each of these kind of points in turn. There are some important things though. So I've gone from Section 3 and defining what capacity is for the purposes of the statute, back to Section 1, which is where some of these kind of real founding principles, or sort of foundational principles are, rather. So one is that there is an assumption of capacity. 2 is that we have to, sorry, I'm just going to admit somebody else. Hello and welcome. That we have to take all practicable steps to ensure that the patient understands the information, can retain, etc., the information that we're giving to them. And I'll come on to that in a moment and give a little bit more explanation about that. And then the last point is that we need to be able to distinguish between incapacity and a really crap decision, or a decision that we all think is bonkers, but isn't actually being made by someone who's incapacitated. It's just a bad idea. It's just a bad decision. And that can sometimes be quite a fine line to tread. So let's just work with this assumption of capacity in Section 1 initially. So the interesting point, I think, first of all, is that this can't be stressed enough, which is the burden of proof is not on the patient to establish that they have capacity. It is on the doctor or on the medical treating team, if they suspect that a patient does not have capacity, to establish that the patient doesn't. So it's the burden of proof is not on the patient, it is on us. And the standard of proof is the balance of probability. So is it more likely than not that this patient does not have capacity. It's not the kind of criminal level of proof where it's, beyond all reasonable doubt. But, on the balance of probabilities, does it look like this patient does not have capacity? But the patient doesn't have to do anything at all. The assumption is that when they present to A&E or wherever it is that we come across them, they have capacity. All practicable steps is an interesting one, because we're all busy, and sort of part of the theme and the thread of my previous consent presentation was that a lot of the kind of hurdles that we need to clear legally are hard for us to clear in this modern NHS, and the NHS that we're all working in at the moment, which is kind of creaking and crumbling and cracking at the seams. We don't have enough time. So, but in relation to all practicable steps, first of all, has the patient been given all of the relevant information? So if we told them everything that they need to know in order to make a decision, have we given them information about all of the alternatives? Could the information that we're giving to them or trying to give them, could it be explained or presented in a better way? And the most sort of basic example of this would be a patient who can't read, then we need to give them the information in a different way. Is it a patient who doesn't have English as their first language? Then we need to give them the information in a language that they can understand. So could it be explained or presented in a better way? Is a particular time of day better for the patient? So for some patients, ITU patients, for example, patients with delirium, with infections, or dementia, all sorts of things. Sometimes some parts of the day are better for those patients than others. They understand and can satisfy that sort of 4-stage test in section 3 at certain times of the day, and perhaps not at other times of the day. And you don't have to have capacity all of the time, as we'll come on to see, in order to consent to a procedure or to a treatment or whatever it happens to be. So it is a certain time of day better for the patient. Could it be put off? Sort of flip side to the last point, really. Could we put this off to a better time for the patient? Are they just distressed about something that's kind of got them in an absolute flat spin and they can't make a reasoned decision? Should we come back later? Can we come back later? The courts have been really clear about the fact that time, and this is sort of what I was alluding to earlier in relation to sort of the modern NHS, or the NHS that we're working in at the moment, where we're under time pressures and we're kind of running around like headless chickens half the time. Only in an emergency is time a factor in relation to what is practicable in terms of communicating information to a patient. So what the courts are basically saying is it doesn't matter if it takes you a long time, you still have to do it. Incapacity versus an unwise decision. So we've kind of looked at the assumption of capacity, practicable steps, and now looking at the difference between being incapacitated and just making a really dodgy decision. And good grief, I last presented this a few weeks ago when this was the most recent dodgy decision that I was able to come across. I could replace this picture with so many more, given the events of the last sort of 2 weeks. However, I'll stick with this one. So is the person incapacitated? Big question here. Or have they just made a really, really, really bad decision? Really interesting case in 2014, so in the Heart of England NHS Foundation Trust, where the court said that the temptation to base a judgment of a person's capacity on whether they seem to have made a good or bad decision, and in particular upon whether they have accepted or rejected medical advice, is absolutely to be avoided. I think that's a really interesting point, that it's really easy for us because we're in it and we know, or we think we know, well, it's a good idea to do this, or it's a bad idea to do that. And but the temptation to base a judgment of capacity on whether they seem to have made a good or a bad decision, and particularly on whether they've accepted or rejected medical advice, is absolutely to be avoided. And any tendency to do that on the part of the medical profession risks infringing the rights of a group of people who, though vulnerable, definitely vulnerable, are capable of making their own decisions. So many of people who suffer from mental illness, they're perfectly capable of making decisions about their medical treatment. And it's really important not to make, as the court says, unjustified assumptions to the contrary. One of the really classic things that I come across in anaesthetics and surgery is this sort of blanket statement that the patient has dementia and therefore can't consent, and that's not true, and it's not the case. Or so I had a case last last Tuesday. Yes, last Tuesday. I was on call this Tuesday and last Tuesday. Last Tuesday, a patient who's got schizophrenia, and the surgeons had just done a straight consent form 4 for the patient. Just assumed that he's got severe schizophrenia. His family had said, yeah, he's pretty up and down. And had said that he didn't have capacity. When he came to, he needed an emergency laparotomy. When he came to the anaesthetic room, and I chatted to him, and my registrar had said, he's got the consent form 4. It just seems a bit weird, but anyway. So I chatted to him and just said, hi, do you know where you are? Yes, I'm at St. Thomas's Hospital. Do you know what's happening? Yeah, I've got a problem with my intestines. Do you know what they're going to do? Yeah, they're going to open it up, and if there's something wrong in there, they're going to take it out. It's just like, well, this guy has capacity. I don't care about his schizophrenia. He's got capacity, and it was a big, massive bun fight with the surgeon to get them to come back and do a consent form 1 for the patient. But it's so easy to fall into these traps and to fall into groupthink. I think this is true across so much of medicine, but particularly in relation to this particular area. Really easy to fall into this sort of groupthink that, oh, they don't have capacity. They've got schizophrenia, they don't have capacity. They've got dementia, they don't have capacity. You go to a ward and you're told, oh, it's a difficult family, it's a difficult patient. I always kind of try and dump those perceptions and assumptions that someone else has made and go in and make my own call about it. And usually I don't particularly agree with the other assumptions. It's often, here's a really stressed person, here's a very stressed member of the family, here's a really scared patient. There's lots of other factors. So anyway, I'm veering off slightly, but in relation to this, I think you get the point, I hope, which is that don't get sucked in by the groupthink. Evaluate every single patient on their own merits at the time that you meet them is the really important thing to do. This is one of my favourite quotes I think ever from a case, which just means that I'm a bit of a law geek. But in GI and local authority, Lord Justice Davis said this. Said, it is of course the essence of humanity that adults are entitled to be eccentric, entitled to be unorthodox, and entitled to be obstinate, entitled to be irrational. Many are, and you and I will have met many of them in our A&Es and on our wards. But the decided authorities show that there can be no power of public intervention simply because an adult proposes to make a decision or to tolerate a state of affairs which most of us would consider neither wise nor sensible. And I think that kind of really sums this up. People can be weird, people can be quirky, all kinds of stuff. They're allowed to be. The law is not going to step in and say that they don't have capacity just because they're doing something we wouldn't do, they're doing something we don't agree with, they're doing something that we think is a bit weird or a bit strange. The bar is way, way higher than that. So we've got this kind of a bit of a spectrum. So at the one end, we've got, the patients who are clearly incapacitated and who need us to help them and to act in their best interests. We've got the patients at the other end who are making really unwise, weird, quirky, strange decisions, but they're allowed to. And so this bit, the green bit, is personal autonomy. We're all allowed to be a bit weird. We're all allowed to be a bit crackers. Just to sort of go back over then this idea that the patient, in order to be able to say that they do not have capacity, stage 1, and there are 2 stages to this, and I'll go over stage 2 in a moment, but stage 1 is that the patient must be able to understand, retain, weigh in the balance, and communicate the decision that we're talking about. So let's start with understanding. Important point here, I think, is that capacity is decision specific. So a patient can have capacity in relation to one thing and not in relation to another. That's sort of true of any patient. But the issue is in relation to this thing, this specific thing that we're talking to the patient about, do they understand? Do they understand the nature of what we're talking about, the nature of the procedure or the treatment or not treating? Do they understand the purpose of it? And do they understand the effects of it? Do they understand the reasonably foreseeable consequences of deciding one way or the other? And that might be deciding to do it or not to do it. But do they understand what each of those routes involves, whether they decide to go ahead with the treatment or to decline treatment? Do they understand the consequences of failing to make a decision? So not deciding yay or nay, but deciding, I'm not sure. Do they understand what that involves as well? Because we're allowed to say, I'm not sure, I don't know. They don't have to understand every single detail, every bit of the, every sort of tiny little kind of bit of the minutiae. They need to understand the salient details. And in RET, which is another really interesting case, it's quite an oldish case now, but in RET, the court said that a patient's ability to understand may be temporarily affected by external factors such as confusion, shock, fatigue, pain, or medication. And I put pain or medication and highlighted them because I quite often give a version of this presentation to anaesthetists. And so pain and medication. So quite often this issue comes up for us if we get a patient who we've dropped off. If it doesn't come up preoperatively, i.e. can the patient even consent to the procedure and do we have the correct consent form, then it happens, it crops up in recovery where the patient kicks off post-operatively. And then the question is, okay, well, do they have capacity? This person wants to self-discharge. They seem to be completely compos mentis. But are they being affected by pain? Have we given them medications that are affecting their ability to make a proper decision? But I think all of those things, confusion, shock, fatigue, pain, medication, they all come into play in the hospital and in relation to the work that we're doing with our patients. So that's a little kind of overview of understanding. In terms of retaining the information, I think this is really important, and this is kind of what came in last Tuesday on call for me. So the fact that a person is able to retain the information relevant to a decision just for a short period of time only doesn't prevent them from being able to be regarded as being able to make the decision. So if they can understand, retain, I mean, obviously not in a sort of transient for a second and then got no idea, but if they can understand it in the context of making a decision long enough to make a decision about the procedure, the process, the treatment that we're talking about, then the fact that they then lose it doesn't matter. What matters is that they understood it and they were able to satisfy those sort of 4 tick boxes or the 4 criteria at the time that you were having the conversation with them. So as long as they've got it, it doesn't matter if they lose it later. What does matter, and this is what happened with my patient, is that according to the surgical team, he didn't have it on the ward. And whatever the assessment that was done on the ward, it didn't really matter, because what he did have was, when he was in the anaesthetic room, he had it. He absolutely had capacity. Because it doesn't really matter what had happened before. He's got it now, and you filled in a consent form for someone who doesn't have capacity to consent, and now you have to change it. So it cuts both ways. Patients can have capacity and lose it. They can not have capacity and gain it. So you have to work with that patient in that moment, at that time, what's going on for them right there and then. So yeah, and so in terms of retaining information, I've covered this. So what about the patient who has capacity and loses it? Hopefully I've just sort of covered that. To talk about weighing the information that we've given to the patient, weighing it in the balance, it's an interesting one. So they need to be able to use the information that we give them and to be able to weigh it up, so to consider it, and as I said, to sort of look at it from all sides and make a decision about it. There's no particular standard that they will be held to. They don't have to, sort of write a PhD thesis on the information. They just need to be able to use it and weigh it up. And importantly, they're completely free to consider the information and to weigh it up, and then to decide that they're going to give it no weight or to reject it. That is not a problem. They're allowed to do that. We can't make that decision for a patient. And this happens with particularly with some religious beliefs, so that a person may choose to give no weight to a piece of information. So, for example, on the classic one that I come across as an anaesthetist is dealing with a patient who's going for surgery, who's a Jehovah's Witness, particularly if it's likely to be surgery that will involve quite a lot of bleeding. The person understands, they know, and they but they choose to give no weight to the fact, or they choose to disregard the fact that if they bleed and I'm not allowed to give them a blood transfusion, that they'll die, or they're likely to die. It doesn't mean that they don't have capacity. They've considered the information, they've weighed it up, they've chosen to give it no weight, or they've chosen to, well, they've not, I was going to say reject it. I don't think they've chosen to reject it. I think they've just chosen to give it no weight. It's not important to them. It's more important to them that their religious beliefs are adhered to. But again, like everything with law, it's a fine line, and the very clear areas at either end of the spectrum are obvious, and it's the grey bit in the middle that's tricky. And so some beliefs might well mean that a patient can't really weigh up the information. They're so kind of dominating that they can't weigh up the information, and in those circumstances they lack capacity. And so this is one of the leading cases, or the leading case really in this area. So local authority in E, which was a young patient with severe anorexia. And she could certainly understand the information that she was being given, and she could retain it, and she could communicate her decision. But she basically had an obsessive fear of weight gain and just an absolute compulsion not to consume calories, and that made her incapable of weighing the advantages and disadvantages of eating in any meaningful way. And you can say, well, how's that different from a Jehovah's Witness? And the answer is, it's a question of degree, and to some extent it's a question of feel, but you sort of know it when you see it in either direction. And I think you can, you know, her beliefs, her obsessions, or her obsession and her fear made her incapable of weighing. You know, she didn't really weigh it at all. She didn't take it into account at all. So it wasn't a case of, okay, I'm going to consider it, I'm going to look at it, I'm going to look at it from all angles, and I've decided that I'm not going to attach importance, or this is a risk that I am going to run, which is sort of what the Jehovah's Witness is saying. But that's not what she was saying in this case. So I think that's really important, that kind of weighing in the balance, the ability to do that. And then communicating the decision. This is kind of obvious, but, you know, it doesn't have to be verbal, it doesn't have to be written, you know, it just needs to be a way of communicating. It might be a blinking an eye, it might be squeezing a hand, it might be, you know, there's all sorts of ways of communicating the decision, and most people are able to do that. And if they're genuinely not able to do it in any way at all, then that probably tells us they don't have capacity. So just a quick recap, that our patients need to be able to understand, retain, weigh in the balance, and communicate. Well, let's understand, retain, and weigh in the balance the information, and then communicate their decision to us in relation to the information. The second step or stage or hurdle that I mentioned earlier is that there then has to be a causal link. So if we think that a patient can't understand, retain, weigh, communicate, any or all of those, then we can't just say that they don't have capacity because of those things. There has to be, you have to satisfy a second test, a second step, which is that there has to be a causal link. So the reason that they can't do that must be because at the material time, they can't make those decisions, or they can't make a decision for one of those reasons because of an impairment of, or a disturbance in the functioning of, the mind or the brain. So it's not enough to say, oh, I don't think they can understand, or I don't think they can retain, or I don't. The reason that they can't must be because of this. And if it's not, then they don't lack capacity. They may have some other mental illness, they may have some other issue going on, but they don't necessarily lack capacity, and the Mental Capacity Act doesn't come into play. So there's causal links. So if a patient can understand, as I've just said, if they can understand, retain, weigh, communicate the relevant information, then they may lack capacity. But I've put this here, reduced capacity is not a recognised legal concept. It's a bit like being a little bit pregnant. It's all or nothing, I'm afraid. So, but as I said, you can have capacity for one thing and not for another. You can have capacity at a certain time and not at another time. You can have it and lose it and have it. But reduced capacity is not a thing. But then there's this further requirement. So that it must be the inability to understand, retain, weigh, and communicate must be because of an impairment of, or disturbance in the functioning of their mind or their brain. So finding that the inability to decide, to make this decision, is referable to or significantly relates to an impairment or disturbance is not enough. Similarly, in the NCC and PB and TB case, the court said that the reason must be the effective cause, the primary cause of the patient's inability to make a decision. It doesn't have to be the sole cause, but it has to be the effective cause, the primary cause, the driver of it. So just a quick sort of recap here. So going back to consent, there's sort of these pillars of consent. Capacity is an absolutely key one. Capacity of the information that we give, which is what I talked about in the last session about informed consent and what the standards are that we need to meet in relation to that. And then voluntariness, and of course we're going to assume that patients are being treated voluntarily. Capacity, patients got to be able to understand, they've got to be able to retain, they have to be able to weigh in the balance the information that we're giving them, and they have to be able to communicate their decision to us. I gave my 3 golden rules of consent last time, so I'm going to give them, and they were slightly different to these. But rule 3 for consent, and rule 3 for almost anything that I teach about when it comes to any of this sort of medico-legal or ethical stuff is write it down. And so in relation to this, this is a real minefield. If you think a patient doesn't have consent in particular, then you need to document really carefully and closely. If you've got time, go to your trust legal people, you know, go to your seniors, and they can go to the trust legal people, get their advice. If you're wondering, then follow your instincts. It's a bit like when you're wondering, should I do a blood gas? Should I put a central line in? Should I intubate a patient? The answer is yes, just do it. So go get some advice, but document everything. It will help you. It will save you should you need to be saved. So rule 1, write it down. Rule 2, write it down. Rule 3, write it down in relation to capacity, consent, anything that you're doing. Thanks so much for listening. These are all of our sort of EveryDoctor social media sort of links and things. I popped my email address up at the start as well. If anyone wants copies of the slides, then you're very welcome. Just drop me an email and I can send those to you. But also this presentation will be uploaded to our YouTube channel as well. So I don't know, does anyone have any questions that they would like to ask? I'm going to stop sharing my screen completely and just see if anybody has anything that they would like to kind of chat about, cover any kind of tricky situations that they've come across, or things that they would like to.
Can you hear me?
I'm doing this whilst trying to navigate Zoom. So, anyone got any questions? You just unmuted.
I have a question.
Oh yeah, fire away. Who's?
My name is Isam. There was a patient that came on my ward. She was admitted under Section 2 of Mental Health Act.
Yeah.
After assessment, I could not find impairment of mind, but she refused to go through the stages of the retaining. So she knew my question. She didn't want to listen. She said, "Bugger off, go away," and so. Sadly, this lady died later from smoking, and I was the last one to see her. Her flat is full of rubbish, cluttering. And then the people who did the investigation, they said, "You didn't do capacity." I did capacity.
Yeah.
I thought she had capacity. She did not have impairment of mind.
Yeah.
But they said you can't comment because you didn't do the 4 stages.
I think that's a bit sort of reductionist on their part, really. You know, because you can tell, can't you? If you're trying to interact with someone and they're just being obstructive or difficult, or they don't want to cooperate with you, that doesn't mean they don't have capacity. You know, that just because they won't answer the specific question doesn't mean they don't have capacity. And so I think that whoever's kind of come to that assumption is being a bit simplistic about things. You know, there's a difference between the patient who won't answer any of those questions because they can't, and then I guess you've got the patients who've got a mental disorder. But you were talking about that before, who won't answer the questions because they are paranoid or whatever, and that's a whole other area.
Yeah. That she was paranoid. Well, she was paranoid, and this is part of her personality. She didn't trust anybody.
Yeah.
She disengaged with people.
Yeah, but it doesn't mean she doesn't have capacity. It's like a bit like the thing that I mentioned earlier about the schizophrenic patient and the assumption that he's schizophrenic and has bad times, and so he just doesn't have capacity. But I think it's an interesting one, SM. Actually, I'll give it a bit more thought, because how do you kind of establish capacity in someone that you're pretty sure has it and is just being obstructive and difficult, but isn't actually incapacitated? So can understand, retain, etc., just won't engage with you and won't tell you that they can. I mean, you can't just go doing whatever we think is the right thing to a patient like that, unless we establish that they're doing that because they've got a mental disorder and that the Mental Health Act applies. Well, even then, if it's a physical treatment as opposed to a treatment for their mental health condition, then we can't do anything either, and there are reasons for that. So, but yeah, I'll give it a bit more thought as well. I've never come across that, so
yeah. It was a bit tricky.
I just get to put my patients to sleep. I don't get any of that hassle from them.
Yeah.
Cool. Anyone else? Roseanne, you've got a hand up.
Hi there.
Hi.
Thanks for that. That was really useful. I was just wondering, I'm in Scotland. Are there any significant differences in Scottish law?
Now you've asked a question, haven't you?
The one thing that struck me, I think with the paediatric patients, sometimes children as young as 12 are allowed to be given the chance to have capacity. Yeah. Is my understanding. I think that's one of the main things, but I just wondered if there were any other major differences. So
it's a really good question. I'm not aware of any. No. There are differences in Scottish law and English and Welsh law across the board, but it's something that I can happily look into. And you're right that I kind of gave a bit of a blanket. Well, kids under 16, are considered not to have capacity. It's not that clear cut, but I think dealing with sort of paediatric capacity, Gillick competence, that sort of stuff is a whole session on its own, and it's one that I will do. But as a broad kind of rule of thumb, both in England and as far as I'm aware in Scotland, that's the sort of the baseline assumption. But it's open to clinicians to say, actually, this is a 12-year-old or a 14-year-old who gets this, who understands, and and I suspect as time has moved on and kids have access to so much information and so much data, they're perfectly capable of knowing about things. Our kind of matriarchal approach is a bit less valid. But I will look that up. So that all of the medical law textbooks that I use, and sort of glancing over at the shelf now, they're English and Welsh, but the main one is actually written by Professor Ian Kennedy, who's Scottish. Yes. That I use. So I will double check, but it's normally those books will say if there's an exception for Scotland, and I certainly haven't come across anything, but I will check it up.
No problem. Thank you.
No problem at all. Pleasure. Anyone else got any questions or any sort of burning issues or sort of tricky situations that you've come across? So my one with the surgeon last Tuesday night at about 10 o'clock at night was an interesting and tricky one, and I had in mind the fact that I was going to be doing this session, and that I do this session for in various sort of ways for different groups of doctors, and this sort of fairly pompous surgeon was he was extremely grumpy with me about the fact that I'd suggested that perhaps the assessment on the ward wasn't, I wasn't saying that it wasn't valid, just that things had changed. And he absolutely laid into me in front of all of his juniors and nurses and things, and I kind of interrupted. I'd never met him before, I'd never worked with him. Interrupted and said, look, can I just stop you for a second, because I just thought, I don't want you to look like an idiot when I say what I'm going to say at the end of this conversation, which is, I'm a barrister, I'm an expert, and I teach on this, and I give expert evidence on this, and I don't want you to look like a complete numpty. But he would not let me speak. He was a real, and so he proceeded to mansplain slash surgeon splain capacity and consent to me, at which point I then had to say to him, look, I'm really sorry, but and he's been quite friendly with me ever since, but it was an interesting experience, and kind of really demonstrated the sort of bit of just the fact that we are not well taught about this issue at all. I think as medical students, I hope that's changing, but as medical students, as junior doctors and more senior doctors, we're just not. So we kind of just fumble our way through and find our way through, and then we get told things by the members of the team or members of different teams and think, oh, that's true, that sounds right, or that's how it's done. But it's a really difficult area, and so I hope that this has been a little bit helpful. I think probably the next session that I'll do will be, I was going to include it in this session, but I also am mindful of the fact that everyone's had a day at work and stuff, and I don't want to have you all glazing over, but it's probably to talk about deprivation of liberty standards, or DOLS, which kind of ties in with the capacity issue, but it's a whole other area as well. So I think DOLS and also sort of paediatric consent, capacity and paediatric issues are worth covering as standalone topics. So I think those two will probably be next. But if any of you guys have any ideas for topics and things for me to cover, issues that are sort of tricky for you, or that come up all the time and you just don't really get a clear answer to, then please just drop us a line. It can be at campaigns@everydoctor.org.uk or legal@everydoctor.org.uk, or I am the simplest of simple, Megan@everydoctor.org.uk. So please do just drop us a line, and we'll do everything we can to try to help with all of that. As I said, this has been recorded, so the YouTube channel, it'll be uploaded to the YouTube channel probably in the next few days. So if you've got colleagues and friends who haven't been able to join, then do get them to have a look if you think it would be helpful to them. And if any of you would like a bit of teaching in your departments, I can't guarantee that I can actually physically come to the department, but I do a lot of, you know, morning meetings, grand rounds, that kind of stuff on any particular medical legal topic. So drop me a line. I'd be very, very happy to do that. So wonderful. We'll go and have a good rest of your absolute. Oh, so hang on, Fozia. Have you got a question? Or is that just kind of like a wave of,
no, thank you.
I'm done.
Thank you very much.
Absolute pleasure. Thanks ever so much, everybody, and take care, and hopefully see you in a month or so's time.